So thank you for joining us for Medicare 101. Robin Dawson of Medicare Solutions Network returns to the Deerfield Public Library to address cost-saving strategies for the years ahead and what to think about as the annual enrollment approaches. This program is being recorded. A link to the recording will likely be available tomorrow afternoon. And join us on October 19th at 7:30 p.m. for Thinks and Drinks Trivia at the Deerfield Golf Club. We like to get outside of the library sometimes. Snacks will be provided free of charge and drinks will be available for purchase. Prizes will go to the top 3 trivia buffs. So the theme is going to be spooky. If you like to wear Halloween costumes, then you're not going to want to miss this one. So, all right. If you have a question, you can put that in the chat at any time if you're joining us virtually, and we'll get to those when we can at the end of the program, or if it's timely during the program. If you are in person, if you could silence your phones, that would be great. Okay, we'll get started.
All right, well, thanks for coming, everybody. I really appreciate Deerfield having me back again tonight. I'm pretty passionate about this topic. I know it can be confusing for a lot of people. And so I want to encourage you to ask questions throughout the presentation. I'm happy to address them. Keep them as general as possible. Anything more specific, you can always reach out to me afterward, okay? We're here to help. There's never a cost for our services. We're here to help you navigate through the confusing maze of Medicare. We started doing this program, oh gosh, I want to say about 10, 12 years ago. This isn't working now, so I'm not sure. The clicker.
Okay.
But I'll just
use, okay. Okay.
Okay, there we go.
Okay.
Because a lot of our clients were coming to this part of their life and they felt a lot like this guy. We also were meeting people that had been on their Medicare journey for 5, 6, 7 years, and maybe something happened and now they needed to revisit their coverage, right? Life changed, their budget changed, their healthcare needs changed. And this is how a lot of people feel this time of year, even if they've been in Medicare for a while and they don't feel like anything dramatic has changed in their life. Why? Because you're a very marketed to population of people, all right? We have a very highly competitive insurance market in this state of Illinois. And as an insurance agent, I think that's wonderful. I love for people to have choice, but it can get a little overwhelming when you're trying to navigate through all of your options. So this time of year, I usually tell people in Medicare, if I have any advice for you, it's to ask yourself a couple of questions. Has anything changed with my health? Has anything changed with my lifestyle, my budget, how I need to move through the healthcare system? Have I acquired any new doctors? Have I acquired any new brand name medications? If there's a yes answer to any of those questions, then maybe it is time for a review of your coverage. If everything's working well and knock on wood, it's affordable coverage for you. And if it ain't broke, don't fix it is what my attitude is. Now, does that mean that you're going to stop getting tons of mail from insurance companies? No, you're going to get that. And for those of you who are about 64 and a half or ready to turn 65, you're probably getting twice as much as the average person, right? Because everybody knows you're about to age into your Medicare eligibility. Now, it's your choice if whether you want to come to Medicare at age 65 or not, but we're going to talk about those enrollment windows tonight. We're going to break down your options for coverage, but more importantly, we're going to talk about what Medicare does and doesn't cover, right? Because it's hard for you to make insurance choices about other things you might want to wrap around your Medicare benefits if you really don't know how the Medicare system works and what the basics are. So I started, like I said, we started teaching this class over a decade ago, but I appreciate the fact that people come to these seminars to learn a little bit more, but they may not want to sit down with an insurance agent right away until they've done a little bit of their own research. So we talk to friends and family, and they mean us well, but remember, their situation is very different than yours, okay? And so how they sort of started their journey and how they navigate through it in Medicare might look very differently than you, okay? So now's the time to get pretty selfish. There are a couple of really good government resources out there for the public to get themselves educated in addition to coming to events like this. One of them is this book, the Medicare and You book. If you're already in Medicare, this gets mailed to you annually, and they started shipping these publications a couple of weeks ago. I was in Elmhurst last night. I had a number of people who had their books in hand, right? This is a great book. It's the Bible of my industry. It answers a lot of questions that people commonly have when they first come to Medicare.
Unfortunately, it's only mailed to you once you've enrolled in Medicare. And the people who have a lot of these questions are the people that are embarking upon their Medicare journey for the first time. So my next favorite resource is Medicare.gov. And that's a place where under this basics tab at the top, or these are all drop down things, you can get to forms, help, and resources. And the forms and publications section is where you can download a copy of that Medicare and You book. You can also email them, or you can call my third favorite resource, which is 1-800-Medicare, and they'll ship one right to your house for free. Okay. So the publication, the Medicare website, and 1-800-Medicare, the phone number. Those folks are on those phone lines 24/7. Almost 365 days a year. I think they're closed for about 6 national holidays. So if you're lying awake in bed at night wondering if you should change your plan or your prescription drug coverage, they can assist you. Okay. The best thing about this website is you can navigate to just about anywhere you need to go to get just about any answer you need to get to. Everything on this website is clickable. I like this tab down here on the bottom, this Find Health and Drug Plans tab. That's where we research a lot of the new plans that are coming up for the coming calendar year, and where we look at plans this year in 2022 for people who might be jumping into Medicare here in the fourth quarter. If you navigate to signing up, there's links where you can click through. If you're signing up for the first time, you're actually going to get pushed to the Social Security website. Okay. Please note the URL of this website. It's Medicare.gov, G-O-V. Social Security is SSA.gov for Social Security Administration. The Centers for Medicare and Medicaid, CMS.gov. Here's my 10-second PSA announcement. The government will never call you. If someone's calling you and they're telling you that they've been assigned to your case and they have a little bit of information about you and they want to help you with Medicare, guess what? They're a sales agent and they're trying to sell you something. So the government likes to communicate with us via snail mail. We can start our process here and we can navigate to a lot of different areas of this website. If you get down the rabbit hole, you've always got this search box where you can type in some keywords to get back to where you needed to go. But if you want to sign up for the first time online, you've got a couple of ways to do it. You can call and schedule a phone appointment. You can go into the office, or you can navigate either through Medicare.gov or go right to the Social Security Administration website and go to the I want to sign up for Medicare only button. Now, there are a lot of people who will come to Medicare and sign up when they're first 65. There are some people that will age into their Medicare eligibility prior to age 65. Those folks are dealing with some health challenges. They might have end-stage renal disease, Lou Gehrig's disease. They may have been on disability for a number of months. Okay, someone who's collecting disability income and they've been declared disabled by the government, they are, when they're on disability for 24 months, on the 25th month, their Medicare card just shows up in the mail. Now, they don't have to take those benefits. They can sign the back of the card and decline it. But those would be the only circumstances under which somebody would qualify for Medicare under age 65. The rest of us, we have to wait till age 65 for our initial eligibility. Now, we don't have to necessarily sign up at age 65 if a few things exist. Number one, we have an employer-sponsored plan. And it's our plan that we're, from our company that we're actively working for, or maybe it's our spouse's, but it has to be based on somebody's active work status, either ours or our spouse. And the employer actually has to have 20 or more people. Okay. That's considered creditable coverage in the eyes of the federal government for you to defer on your Medicare benefits until a later date, later age, without penalty. Okay. Now, most Americans, they have contributed into the Social Security system their entire working life. 10 years or 40 working quarters will give you enough tax contribution into Social Security that will allow you to have a zero premium Part A benefit. And if that is the case for you and for most people, and again, if you stayed home and raised the kids and your spouse was the one that worked, as long as they have enough credits and you're able to take advantage of that, you can go into Social Security and get a zero premium Part A applying under their tax contribution. But that's that's kind of the general rule of thumb. So most people do qualify for a zero premium Part A. And they don't have to sign up when they're first eligible. For people who maybe contributed into a pension their working life and they didn't contribute into Social Security, they might not have enough tax credits. So that's something to check, because if you don't, and you're going to have to pay some amount for your Part A premium, that will be determined by Social Security, and you will be required to sign up when you turn 65. Okay. Question from the audience.
Yeah, just real quick, in my understanding, you still have to, once eligible at age 65, you have to sign up for A, but you don't have to sign up for B. You're saying
That is an incorrect statement. You don't. So you don't have to sign up for A if you qualify for a zero premium Part A. Okay. If you don't, then yes, you do. So again, Medicare is filled with a lot of partial sentences, half-truths, floating asterisks. A lot of these government publications, the website, the book, they're written for the masses, right? And so if this, then that is kind of the direction of, there might not be the same answer for every individual depending on their circumstance. Okay. The one thing I want everybody to be aware of, besides the fact that everyone initially qualifies for Medicare at age 65, is that Medicare was never designed to cover everything. There's always been gaps in that coverage. Okay. The federal government designed Medicare so we would have skin in the game, so to speak, deductibles, co-insurance, co-payments. And so we're going to talk about that tonight and what your financial exposure is under Medicare. This is where your journey begins. This is your red, white, and blue card. Now, my parents' generation, they retired at 65. They turned on Medicare. They went and took the grandkids fishing, and they moved into the next phase of life. So when they enrolled, these dates were exactly the same. Their Part A benefit and their Part B benefit started on the first of the month in which they turned 65. That's when everybody's eligible. Okay. Now, you actually have a 7-month window, and that's why I have this little chart down below the Medicare card on this slide. You have a 7-month window in which you can sign up for your Medicare benefits. They don't expect you to do it, right on your birthday. You could do it 3 months leading up to your birthday if, in fact, you want your benefits to start on the first of a month. Okay. Doesn't matter if your birthday's on the 15th of the month or if your birthday's on the 30th of the month. Everyone that month is eligible on the first of that month. And if you enroll in the 3 months prior, that's when your benefits will start. If you wait until the month of your birthday or the 3 months after your birthday, that's fine. No harm, no foul. You're not going to be penalized for anything, but your Part A benefit will be retroactive to the first of the month in which you turn 65. Your Part B benefit may be delayed by 1, 2, or 3 months respectively. Now that's in calendar year 2022. I believe in 2023, what they're going to do is only delay your Part B benefit by 1 month if you enroll in this back half, okay, in the month of your birthday or later. But you do have the full 7 months where you can sign up or not. Now, why do people wait? Well, because Part B is adjusted for income. So just like taxes, the more you make, the more the government will take. And if you are a joint filer, look down the joint filer column. If you are an individual filer, they're going to follow this column. But what they're going to do is if you come to Medicare this year and you sign up in November, let's say, they're going to look at the most recent tax return they have on file for you. And as an individual or a joint filer, they're going to be looking at the modified adjusted gross number on that return. And if you're above these thresholds, your Medicare premium might escalate. Now, the base premium for Part B that every American pays is $170.10 per person per month. It's going to go down a little bit next year, which is good news. But how you're adjusted for income looks like this in this calendar year. Now, that income related monthly adjustment amount, if they tag you with it on Part B, they might also tag you with it on Part D, your drug coverage. And that's what this looks like. Okay. So the drug plans, they're sold by private insurance companies. They vary in price. So what they do is once they determine your income threshold, they just tack on this additional amount on top of your premium in perpetuity, okay, every month until they reevaluate this. Now, they will look at your tax return on a rolling 2-year basis. So if you're adjusted for income initially, you might not have to live with that forever. I certainly would encourage you to appeal that determination when you get the letter from Social Security that shows up after you enroll and says, congratulations on earning a decent living. You owe more for Medicare. I encourage you to appeal that if you're going to be retiring. Okay. Because if you're retiring, you're not going to be making that kind of money anymore, right? Theoretically. So if you want to fill out that form, send it in with the supporting documentation. The worst thing the Social Security office can say is no, right? And then you pay the higher amount until the redetermination. But if they say yes right away, they might roll you back a bit. And if you're looking at, if you're a high wage earner and you're looking at premiums in this range, every little bit helps, right? Every little bit helps in a rollback. Just know that this is constantly reevaluated in your lifetime. And we do all kinds of things when we retire, right? We cash in part of our 401k. We might take stock, sell some stock. These will all create taxable events for us that might have a ripple effect back to our Part B premiums. So just be mindful that that's how Social Security is looking at this. Now, why do people wait on this Part B? Well, they might be on a group plan and they might have a number of dependents on that plan, and they don't want to throw those people to COBRA or the Affordable Care Act, right? So they might hang on to their group insurance even though they're Medicare eligible, okay? If that's not your situation, if it's just you that you have to worry about and you fully intend to work for a couple more years past age 65, which a lot of baby boomers are doing, you have a choice. And we can do a cost analysis for you and look at your employer group plan and look at Medicare. You're going to learn a lot about what Medicare is going to cost tonight, in addition to that 170/10. But one of the things that you can do when you are armed with that information is, to make that decision for yourself. Is it worth it to stay on my group plan or not? Just because you're going to continue to work past age 65 doesn't mean you need to take your employer insurance, right? Now, you might want to. It might be a really good deal. It might be very affordable for you and be really good coverage. And in that case, stick with it. You don't necessarily have to fire any of this up. Okay. But just remember that has to be based on your active work status or your spouse's, and it has to be with an employer of 20 or more people. If one of those things doesn't exist, if it's a retiree benefit, a COBRA benefit, maybe you retired at 58 and your employer loved you, so they let you keep the employer insurance, right? But at age 65, you're going to have to get to Medicare and turn on Part A and B for sure. Can no longer be primary because you're not actively working, you're retired. Similarly, if you work at a small law office or a small dental practice and there aren't 20 people there, okay, they're offering you group insurance, you can still continue to take it as secondary, but Medicare is going to have to be primary for you. Okay. So what happens when people defer past this 7-month window? Well, you can turn on your Part A, like the gentleman said earlier. Can't hurt you if it's zero premium, right? It'll just sit in the background behind your group benefits. Okay. The only circumstance under which I might tell somebody not to turn on their Part A, even if it's a zero premium benefit for them, is if they're contributing to an HSA. Okay. A lot of people like these health savings accounts. Sometimes their employers contribute to them too, because it allows them to stuff away money tax-free and use it tax-free coming out for healthcare expenses down the road. And they want to continue to contribute to that as much as they can before going to Medicare. If you turn on any part of Medicare, even Part A, you're no longer going to be able to make tax-free contributions going forward. Okay. So again, a lot of different variables here as to whether or not people should or shouldn't turn on their benefits when they're first eligible. So if you defer on your Part B, you will later, at some point in the future, come to Social Security under what's called a special enrollment. And that'll be dictated on when you're deciding to either step off your other qualified coverage or retire, whatever the case may be. And you're going to fill out your Part B application and you're going to have a second form. It's called proof of employer coverage. You're going to fill out the top half, your employer is going to fill out the bottom half. And those two forms are going to go together to turn on your Medicare benefits at a later date. Okay. But you got to show that proof of creditable coverage form or your application will not be processed. Right now, if you miss your initial enrollment window, if you miss any special enrollment window, life's happening and you forget about all of it. People can always jump into their original Medicare benefits, Part A, Part B, in the first quarter of every calendar year. The challenge with doing that is your benefits are going to be delayed. Your Part B benefits, they're going to be delayed till July 1st. Doesn't matter if you sign up on January 2nd or March 31st. Everybody who enrolls in that window is delayed until July 31st. And if you don't have other creditable coverage in that interim period, you're going to probably pay a late enrollment penalty for your Part B and your Part D. Okay. Did we have a question from the virtual audience? Okay. Will do.
Jeff is asking if contributing to HSA and are 65, is it true that you have to stop contributing 6 months before you decide to start taking Medicare?
So the question about contributing to an HSA, one of the things that you will find in a lot of the government publications like Medicare and You and the government website is there will be guidance that says stop contributing to your HSA 6 months prior to enrolling in Medicare. And the reason is because when you enroll in Medicare Part A at a later date, your benefit will always start retroactive 6 months from the date you apply. Part B is always a forward, it's a forward enrollment. Like if you enroll in November, it starts in December, right? But Part A gets rolled back by 6 months. Now it will never go back further than the first of the month in which you turn 65, because that's when you were first eligible for that benefit. But let's say you're now 70 and you're finally deciding to retire and turning on Part A and B for the first time. Your A benefit's going to roll back by 6 months. So just plan accordingly with your tax accountant and your HSA contributions, because you don't want that overlap, or you might have to pay some money back to the federal government because you overlapped on when your Part A was active. Okay. All right. Let's talk about the 4 parts to Medicare. Medicare Part A and B. This forms the foundation of our coverage from the federal government. This is what shows up on our red, white, and blue card. Medicare calls Part A our hospital insurance, but it covers you for more than hospital care. And we're going to break that down tonight. If I had one word for Part A, I would say it's your facilities coverage, and you'll see why in a minute. Medicare Part B, this is the big piece. This is the lion's share of where your bills are going to go. This is what Medicare calls your medical insurance. I would call it all of your services coverage, right? Because anybody that provides a service to you, a doctor, a lab, or that's going to bill to Part B. Medicare Part C is a different idea. Okay, it's a Medicare part of Medicare, but it is actually a private insurance product from a private insurance company, and it administers your benefits under A, B, and very frequently D. There are some plans that don't include D, but Medicare Advantage, for the most part, there's a lot of plans that include all 3 pieces, A, B, and D. Now, why does that exist? Well, because there's still 10,000 baby boomers turning 65 in this country every day, and people coming into the Medicare system in droves. And so the government's happy to pass off the responsibility of administering those benefits to private insurance companies. And so this is a very competitive space, just like the drug plan spaces and the Medigap spaces. But Medicare Advantage plans are not supplement plans. They are not Medigap plans. Okay, those are different products that we'll talk about tonight. These plans actually take over for Medicare. In the insurance industry, we call them Medicare replacement plans. Now, you still have to be signed up for A and B to get a Part C plan. You still have to be paying in to the Social Security system for that coverage, okay? But this is a replacement plan to Medicare. And then Medicare Part D is simply prescription drug coverage. It's the one piece that the federal government does require you get when you step off of other qualified drug coverage, which typically is bound up in your employer or union or retiree benefit plan, okay? So once you kick that to the curb, you got to get Medicare Part D within 63 days, or again, you'll be penalized for late enrollment. So let's look at the 10,000-foot view of Medicare. This is the first page of your handout. For those at home, you got this emailed to you, I believe, with the link to the Zoom tonight. I don't know if you put it in the chat, but we can always send it to people after the fact if they don't have it. But I like to make a fairly complicated topic simple, and I think visuals help. So when you come to Medicare and you turn on Part A and B, your foundational coverage, there's really 2 paths you can travel. Now, remember earlier tonight, I talked about how it's pretty good coverage. And I hope tonight you leave realizing that you're getting a pretty good benefit for what you're paying, but it is incomplete coverage. And you do need this Part D piece. The federal government requires that you have that drug coverage piece. So you can travel one of 2 paths to put that in place. You can either add a Medicare supplement plan behind your Medicare benefits, and you can add drug coverage separately. And then also things that Medicare maybe doesn't cover for you, like dental and vision, and you can piece all that together. Or you can travel the path of Medicare Advantage, okay? But it is an either or choice. And throughout your lifetime, you can bounce back and forth between these 2 options. You can do so during the annual enrollment, which is between October 15th and December 7th of every calendar year. However, Timing is one thing that you have to be mindful of. Your health is another thing that may preclude you from moving freely on this landscape, particularly to get one of these Medigap plans. Okay. No questions asked to get a drug plan. You get a free do-over every year on that if you want. You can always go into a Medicare Advantage plan without questions about your health, but you have a finite window to get one of these Medicare supplement plans. And it's when you first come to Medicare. Now, I say a finite window, meaning you cannot be denied coverage in that window. You will not be asked anything about your health. If you have pre-existing conditions, it's not going to matter. Every insurance company in the state of Illinois that you can choose from has to take you if you apply for one of their policies. But after that window closes, you can be put through what's called medical underwriting, where you have to answer questions about your health. They will pull your medical records and your prescription drug list. And at that point, they could say, thanks, but no thanks. We don't want to cover you. Okay. So when you hear friends and family talk about, oh, well, you can never move between, partial sentence, right? You might not be able to move at any old time. You know, there's a window within which you might be able to make some of these changes, but also too, your health may be a gating factor. Okay. So let's talk about, before we break down those options and navigating on that playing field, going on the left side of the chart or the right side of the chart, let's talk about what Medicare covers. Okay. Medicare Part A, this is our hospital insurance. It covers us importantly for inpatient hospital care. That's an important distinction, right? Because sometimes we go into the ER and they might not admit us. They don't know what's happening. So they just keep us there for a few hours, maybe overnight, but we're kept under observation. Okay. That stay in the ER, even if it's at Northwestern or Advocate, it's not going to bill to Medicare Part A. It's going to bill to Medicare Part B as outpatient. So once we've been admitted and they move us to a nice comfy bed and say, this is what we've determined, this is how you're going to be treated, and you're going to be admitted today, that's when you trigger your Part A benefit of hospital care. Now, skilled nursing is another wonderful benefit. We can't always go right home to finish our recovery after a hospital stay. Sometimes we have to go onto a rehab facility or post-acute care for a couple of days or a week to get our strength back, okay, get our mobility issues resolved before we can go home. Medicare's got our back in that situation as well. And then sometimes we might be able to go right from the hospital home, okay? But maybe we've got some stuff going on that we need some assistance with, such as we need some wound dressings changed, or maybe we need some administration of medications. We need some infusions or injections. Or maybe we need a handful of physical therapy visits in the privacy of our own home before we can get in our car and drive ourselves to an ATI or some other external facility, okay? That's considered home health services. Our doctor will order it upon discharge. It'll be short-term in duration and a Medicare-approved provider. But Medicare's got our back for that, okay? Part A benefit. And then hospice is also a wonderful benefit, whether it's end-of-life hospice or hospice that leads you back to palliative care. Medicare has us covered under a hospice benefit. Okay, now I mentioned earlier, Part A, for most of us, has no premium, right? Because we've paid for it our entire working life. Not everybody, but for most of us. And so we're not going to pay a monthly cost when we turn this benefit on, but we certainly have financial responsibility when these benefits are triggered. And that looks like this. Okay. Now, the first night we're admitted into the hospital and they actually change our status from observation to admission, or maybe we are already going in for something. It's an elective procedure and we know we're going to be admitted for that procedure. Okay. The first night we're there, if all we have is that red, white, and blue card, Medicare is going to look to us for $1,556 on night number one. Okay. Now that's a big number. However, it covers us upon discharge up and through day 60. So let me play out a scenario for you. You go in for an appendectomy, you have your surgery, you're in and out in 4 days, everything's wonderful, okay? And then 3 weeks later, you have a heart attack and you're back in the hospital for open heart surgery. Okay. You're not going to get tagged with that 1556 a second time because you're within your 60-day benefit window. But let's say you had the appendectomy in February and then you're shoveling the driveway in December or November, if we get a bad snowstorm, and you slip and fall on the ice and break your leg. Okay. And you're back in the hospital for surgery for that. If it's if you're admitted, you're going to trigger that a second time. On benefit on day 61 after the appendectomy, this benefit reset. So now you've got to pay that twice in a year. Okay. Not something you want to think about, but it could happen. Skilled nursing, Medicare has a trigger on this benefit, which is why I have a floating asterisk on this slide. The first 20 days, Medicare is going to pick up the entirety of the bill if we have 3 nights admission, under admission, preceding that stay in the hospital. Now, during COVID, this was tweaked a little, okay? People didn't always need that 3-night admission, but we're back on track with the standard Medicare rules. So 3 nights admission or the first 20 days is not going to be picked up by Medicare. It's going to be picked up on you. And I've seen people, clients of mine fall through the cracks here. They clearly were in the hospital 5 days, right? The first 3 nights, they were under observation. They didn't get admitted till the 4th night. They got treated the 5th day, and then they were discharged on the 6th day, right? So they had 5 nights under admission. The first 3 were under observation. The last 2 were under admission, and then they went on to rehab. Guess what? Guess who got that rehab bill? They did. Okay, because they didn't have 3 nights under admission to trigger the first 20 days on Medicare. So when you're in Medicare, you want to be your own best advocate. Show that red, white, and blue card and ask people, what are we doing? Why are we doing it? And who's paying for it? Right. And if you're in the hospital, ask what your status is. It's a fair question, and they'll absolutely be able to tell you within 10 seconds. Okay. Now, our skilled nursing benefit definitely goes beyond 20 days. My mom was a great example. She fell and broke her leg a couple of years ago. She's in her 80s. She was in rehab for quite a while, okay, to get her strength back. So once she passed day 20, Medicare looked to her for $194.50 in a copay per day. And that benefit is exhausted once you reach midnight on day 100, because this benefit is only 100 days long. Now, it's not 100 days in your lifetime. It's 100 days per occurrence, okay? But with my mom's situation, she definitely went past the 100 days. So on a day 101, you're either in a situation where you're going to long-term care, you're pulling out long-term care insurance, or you're simply paying out of your assets for the balance of that stay, okay? But Medicare caps you off at 100 days. Medicare does not, let me repeat, they do not provide long-term care insurance. Separate topic, separate insurance, separate night, okay? Home health services covered at 100%. But again, your doctor's going to order this. It's typically going to be short-term in duration, and it'll be a Medicare-approved provider. But Medicare's got your back for this stuff. No grocery shopping or house cleaning, but medically necessary things. And then hospice, to be fair, I put 5% coinsurance because sometimes we fill medications to keep us comfortable at end of life. But again, this benefit is robust and covers you in home or in a facility. So that's Medicare Part A, no premium, but definitely financial exposure. Medicare Part B, this is everything else, right? All the doctors you see, all the surgeons that operate on you, all the anesthesiologists that knock you out so the surgeons can operate on you. Anybody that touches you is going to bill to Medicare Part B, whether it's in their office or in a hospital. Any lab work that you might have done, this could be a blood panel or a biopsy. Any of your diagnostic tests, this could be your EKGs, EEGs, MRIs, PET scans, CAT scans, any of the alphabet soup tests. Durable medical equipment is also covered. This certainly could be a walker or a wheelchair, but it could also be a pacemaker or a COPD machine or an insulin pump or the lancets and test strips that you get through the pharmacy, but they're considered durable medical equipment if you're diabetic. New shoulder, new knee. Okay, you could become the bionic man or woman. Some of that's going to bill to DME. Your physical therapy or pain and torture, as my clients like to call it, mental health therapies, occupational therapies, all in here. Ambulance services, so the ride to and from the hospital, that can be expensive. That bills to Part B. Anything that happens to you in the ER, and certainly those overnight stays in the ER or in the hospital where you're kept under observation. But here's the other scenario. There are medical miracles happening every day in this country. And if I had a nickel for every client that told me they had a full hip or knee replacement done on an outpatient basis, I'd probably have a nice stash of cash, at least to take my husband out to dinner. But outpatient procedures are fairly common now. So whether they happen in a hospital or in an ambulatory surgery center, they're going to bill to Part B, not Part A. So again, that's what you want to know if you're going to be in the hospital for any length of time, you know, is this all going to be, am I going to be outpatient for this whole thing, or am I going to be admitted for this? Because then you'll know where your Medicare billing is going to be directed. And then clinical RX, this is the rough stuff. Medicare has our back for chemotherapy, kidney dialysis, radiation therapy, any infusions or injections. Maybe we need injections in our spine or our joints for arthritis. Maybe we need injections in our eyes for, you know, some ocular issues. Anything that's administered in a clinical setting, good rule of thumb, that bills to your medical plan, not your prescription drug plan. Okay. But as you noticed, there's nothing about your pharmacy dispensed medications. What about coverage for my cholesterol or high blood pressure medication? That's Medicare Part D as in drug. Okay. So your medical, even though you're getting medicines when you're getting infusions or injections or radiation of some sort, that bills to your medical plan. Okay. Now, Medicare Part B, we spoke about how that base premium this year is $170.10 per person per month. Okay, everybody pays that. The only people who get that wiped away are people who qualify for state benefits under Medicaid. Okay, but if you're just getting your Medicare, everybody pays that. Good news is it's going down a little bit next year. Okay, in addition, Medicare Part B has an annual deductible. And that this year is $233. That's also going down a little bit next year. Not a bunch, but a little. Every little bit helps. So the Part B deductible is an annual amount. How do you pay that? Well, the first few things you do in the healthcare system once you get to Medicare in a calendar year. So if you're coming in November, right? If you go see your doctor, if you have a blood panel, if you have an X-ray, you're going to pay a portion of that because you're paying off your deductible. Once the $233 is behind you, then Medicare is going to take their negotiated discount, which you're going to love, call it that dash in the middle there. And then they're going to split bills with you 80-20. They're going to pay 80 cents on the dollar. You're going to be responsible for 20 cents on the dollar on all of these things. Okay. Now I mentioned you might be coming into Medicare in November, right? And you might have a ton of doctor's appointments. You're going to pay toward that deductible November, December, and that's going to reset in January. Okay. So that resets on the calendar year. So you may want to time your doctor visits accordingly, but that's a one-time annual deductible. So that's crazy low, folks. I mean, I've looked at a lot of employer group insurance plans, and this is why I say, if you're working past age 65, it is really worth a look at your benefits from your job compared to Medicare, because I've never seen a deductible that low on a group insurance plan. Okay. It's crazy good. And certainly if you're on the Affordable Care Act, you've probably got thousands of dollars worth in a deductible. And then that 80-20 split is good too. So this is all very good news. However, good news, bad news. All right. Medicare is an unlimited benefit. That's the good news. If you need a heart transplant, you need a hip replacement, you need to get chemotherapy in your lifetime, Medicare's got you. You know, you're going to have to pay your 20% coinsurance though, and your deductibles. And maybe if you're hospitalized, you're going to have to pick up that $1,556, or if you have to go on to skilled, but they're going to cover you for whatever comes your way to some unlimited amount, right? Here's the bad news. Unlimited benefits come with unlimited exposure. So your out-of-pocket expenses, they have no max out-of-pocket concept. And we're all used to being on some plan that's got some maximum number. So if we ever have a horrible year health-wise and we pay $10,000 out of pocket or whatever that number is, 7, 8, 9, we're done, right? Medicare doesn't work that way. These numbers can accumulate to some unlimited amount. And 20% coinsurance on an office visit or a blood panel, not such a big deal. We can all manage that. But if we start billing outpatient procedures and ER visits and ambulance rides and maybe clinical RX, that can get real spendy real quick. All right. And nobody wants 20% of some unlimited number. So that's why we go back to our chart and we have to decide, how are we going to round out our benefits? Because we didn't see anything about prescription drug coverage in Part A and B. So we got to add Part D, but we also might want to protect ourselves for that unlimited financial exposure that Medicare requires us to pay. And there's a lot of ways that we can go about doing that. But one of the ways that people will often start with is getting themselves a Medigap plan. Now, Medigap plans have another name. They're also called Medicare supplements because they fill the gaps or supplement what Medicare leaves you open to pay for. Okay, after they pay. So hence the name. But these plans are actually defined by the federal government. And this is the second page of your handout. This is the complete offering of Medigap policies that the government has defined. And this has been in existence for quite some time, okay? I think the last time, recently they made a change to this chart in January of 2020, but prior to that, they hadn't touched it since 2010. Now in 2020, what happened was Medicare said, there's two plans on here that still cover that Part B deductible, that nominal $233, all right? And we want everybody to have a first dollar in experience in Medicare. So we're not gonna let those plans be sold to the public anymore to people who are turning 65 after January 1st of 2020. So if that's you, or if that's anybody at home online, you're not gonna be able to buy that C plan or that F plan or the high deductible version of F, okay? But for anybody else, if you have those policies, you can keep them. If you aged into your Medicare benefits and turned on your Part A prior to January 1st of 2020, you can buy one of those plans. But I, as a broker, might spend about 1 minute or 2 minutes trying to talk you out of it. And here's why. Because when you pick one of these policies from some insurance company in Illinois, because by the way, the government defines what these cover, but they let private insurance companies sell them to the public. So when you choose one of these policies, you're choosing that letter plan from that insurance company. And you're all sharing claims as you age. You're participating in the risk pool concept of insurance, okay? So what we like, what we want, what protects us as we age and file more claims is a really large population of insured to spread around the numbers, right? Well, if you're in an F plan or you're in a C plan currently, or you want to buy one of those plans, guess what? No new healthy 65-year-olds can jump into those policies anymore. So you're in a risk pool, people, that is going to atrophy and start to shrink over time. And I hate to tell you this, but the law of nature is we tend to file a little more claims in the healthcare system as we age, right? So the claims go up, the amount of people you can spread that around shrinks, and that's not going to bode well for your rates. Now, the price of these policies, when you come into them, are generally fixed around your zip code, your age, whether or not you're male or female, and a smoker or non-smoker. After that, that's it, right? So the way that they manage this is the insurance companies will increase your price as you age. Everybody does. Your price will go up a little bit every year as you age. We like to work with companies where that increase is what we call modest, right? What's a modest increase? I tell people budget on average 5 to 8%. Your financial advisor might tell you budget 10% increase on healthcare costs across the board every year, just to be safe, right? That's conservative, but on average, not to say that some years they might not go up 10%, other years they might only go up 3%, but in the life of holding these policies over the term of the years that you're in one of them, 5 to 8% is a good number, okay? But where we see that demonstrated rate increase history is with companies that have been in this business for a while. They got a good track record. I can look that up for you, right? I can't look it up for somebody who's only been in this space for a couple of years. So large companies, large risk pools, long-standing reputation in the business, that's who you want to be looking for. The other thing you want to look at is, are they financially rated by AM Best and S&P? And are those ratings at least an A? All right. I don't like working with B-level companies. Their financial parent company doesn't have financial health in the A rating category, I'll take a pass. You know, there's a lot of choices in the state of Illinois on this chart. And so you want to be prudent about your decision, especially initially, because you can choose anything here without question. You cannot be denied. You might not have that opportunity later in life. Okay. So I'm going to give you a little tip. There are 3 plans that really drive the market. Most insurers sell these plans, and most people fall into one of these 3. If they're going to choose this kind of a product, they tend to choose one of these 3 plans. And the reason is because they're fairly easy to understand, and people like things that are simple. So if you look to the left of this chart under the benefits column, this is all that financial exposure that I just talked about that you're responsible for under Part A and B, right? And so if you look across, the rows and you see 100%, that means your supplement plan, your Medigap plan, is going to wipe away your financial responsibility 100%. So if the Part B deductible has 100%, it's taking care of the 233. If the Part A deductible and coinsurance has 100% in that row, they're paying the 1556. They're paying any subsequent copays that you'll have if you're hospitalized for longer than 60 days, because Medicare certainly does cover us if we're admitted for longer than 60 days. We actually have up to 150 days in the hospital, contiguous. Okay. But what happens after that 60th day is they flip us to a per day copay. So you could have a supplement plan that wipes out all those costs. Heck, you could even have a supplement plan that wipes out that Part B coinsurance. Okay. That 20% at 100%. So that's why people really like these policies. Now, Plan F was popular for a really long time because it took care of everything. And you might have a friend that has a Plan F that says, I love it. You have to get the F. I never see a bill. Well, what they don't recall, because maybe it's on auto drive for them, is that there's a big sucking sound coming out of their checking account to pay for that policy every month. All right. Because the most extensive coverage always rhymes with the most expensive coverage. Okay. So if you want an insurance company to wipe away all your bills, they're happy to do it, but they're going to charge you a little bit more for it. Okay. Now you might say to me, Robin, I'm kind of a healthy guy or a healthy gal. I don't go to the doctor that often. I want to be smart. I want to have all the big stuff covered. But, you know, this Plan G could really fit the bill, right? You're responsible for the Part B deductible. That's the only empty box, $233 a year. But if you're willing to take on the first $233, a Plan G versus a Plan F is likely going to save you $50, $60, $70 a month. Okay. Now I'm not a mathematician, but that's kind of a no-brainer, right? And what we're looking for is value on this chart. We want to be smart consumers about what we're buying. Plan N is also a suitable plan for many people, especially someone that's maybe not dealing with chronic conditions. Maybe they're not in the doctor once to 2 times a month. Maybe they're going a handful of times a year. They're seeing their primary care doctor. They're getting all their preventative care done. But then, they got to see their cardiologist or their gastroenterologist or their urologist or whatever it is. But they're going in to see those docs maybe once or twice a year each. So Plan N, if you bring your eyes down to the bottom of this chart in the disclaimers, Plan N says that 20% coinsurance for all those doctor visits, that's going to be paid for at 100%, but we've got some floating asterisks here. And so on a Plan N, you might have to pay a nominal $20 for an office visit copay, $50 if you go to the ER and it doesn't result in an admission. So you cut your finger carving the Thanksgiving turkey and you needed to get stitched up, you were in and out, right? They're going to just charge you a $50 copay if you're on a Plan N. Okay. So every time you're willing to take on a deductible, maybe a deductible and some copays. Okay. Maybe a deductible, some copays and some coinsurance. Every little bit you're willing to take on out of your pocket, the insurance company will reward you by lowering your premiums. So just spitballing, average female turning 65. If a Plan F is around 165, a Plan G might be around 120. A Plan N might be under $90 a month, maybe 80, 85. And certainly if you're coming with a partner, or if you've got somebody else in your household that's 60 plus, or that is on another Medigap plan with that same company, we're going to take advantage of household discounting wherever we can. Okay. So this is looking at this landscape. You want to absolutely look at price. You want to look at track record in the business and how long these carriers have been doing what they've been doing in this space. You want to look at rate increase history, but you also want to take a rational assessment of your needs. Okay. Your husband might want the G plan and need the G plan for his care. You might want the high deductible version of that plan. Maybe you don't need that much robust coverage. I always tell people, even if you want to get away with the most cost-effective policy on this, you don't want to pay a lot, right? All you want is a firewall behind your Medicare benefits. You can get the high deductible version of the F if you qualify for it, or the G if you qualify for it. That's going to run you as a 65-year-old, maybe $40, $50 a month, depending on if you're male or female. Okay. You're going to have to pay that $15.56 if you land in the hospital, and the 20% coinsurance on all services and your deductibles and your skilled nursing charges. But you're going to get capped out this year at no more than $2,490. So that's how that high deductible plan works. What if you hit that number in a calendar year? Well, then your high deductible plan starts acting like the standard version of itself, and it'll pay everything after that to the tune of these percentages. Okay. So you have very Spartan coverage, you have very lavish coverage, you have coverage in between, okay? You really can dictate what level of backup you want to your Medicare benefits. But I always tell people at a minimum, it's worth getting at least a high deductible plan. So you put in a firewall, okay? You don't want to ride roughshod without any max out of pocket. Was there a question from the virtual audience? Okay.
What are the currently excess charges that N does not cover?
Wonderful question. So Part B excess charges is the only other empty box that exists besides the Part B deductible on an N versus a G plan. There are two types of doctors that participate in Medicare. Those that accept what's called Medicare assignment and those that may not. Okay. If a doctor accepts assignment, they're taking Medicare's negotiated discounted reimbursement rate as payment in full. A doctor who doesn't accept assignment may decide that they're going to balance bill. And if they balance bill, Medicare will allow it, but they can balance bill no more than 15% of what Medicare agreed to reimburse. And that's called passing through a Part B excess charge. If you're on a plan N and you encounter one of those excess charges, you would be responsible to pay it. If you incur it and you're a plan G holder or a plan F holder, it gets paid for you by the supplement company. But let me explain this. You go in, let's give a real life example. You go in for an office visit and the doctor bills $500 for the office visit. And Medicare says you're adorable and talented, but we reimburse for $300 for that office visit. And then you're on the hook for 20%, right? Unless you have a supplement that covers it. So that doctor might say, well, I think I'm, worth more than that. And so I'm going to pass through an excess charge. Medicare will allow it. They'll file the paperwork for it, but the maximum that they could bill you in that situation would be 15% of the $300, not the $5 and not the difference. So that $45 charge would come to you if you were a Plan N holder and you'd have to pay it. If you were a Plan G holder, it would be paid for you by your supplement company. Here's the thing. The last Centers for Medicare and Medicaid statistic I saw said that 98% of all doctors accepted assignment. So really, where you're going to incur more charges if you're on a Plan N versus a G is in copays for office visits or ER visits. So that's one way to kind of help you make your decision between those plans. Now, that's today's state of the world. Things could change, but you can also look up every single one of your doctors on Medicare.gov, and it'll say right there on the website whether or not they accept Medicare assignment. Okay. Question from the audience.
Yes, please. Just to understand, I'm trying to put it all together.
Mhm.
So if you take the high deductible G plan.
Yep.
You would be, it doesn't, according to your chart, it does not cover the Part B deductible.
Right. So
However, with that being said, your maximum exposure, because you would still be financially responsible for the 20% co-insurance.
correct.
But that 20% co-insurance would be capped at $24.90.
Correct. Right. So here,
Am I understanding that?
you are. So the question to the virtual audience was about high deductible G or high deductible F. So in high deductible G, you would be responsible for the deductible under Part B. You would be responsible for the 20% coinsurance under Part B, and you would be responsible for any of these charges for hospitalization or an extended stay in skilled nursing if they occurred, okay? But all of those amounts that you would pay on a high deductible supplement, they would count toward this max out of pocket number down here of $2,490 in calendar year 2022. Now, Medicare adjusts all these numbers every year, but your supplement just aligns right to them, okay? So this might go up a little bit next year, but it's gonna go up tens of dollars, not hundreds of dollars, okay?
And again, it all depends on what your perspective is, whether you're
Correct.
healthy or not, or
Yep.
whether you're trying, the initial reason for insurance is many people view is to cap their maximum exposure.
Mhm.
So that may be an option for somebody to cap it rather than you talk about your unlimited, that caps it at $24.90.
Correct, right. I will never understand why people will just run around with that red, white, and blue card and a prescription drug card. It's a very risky situation when you can get a relatively inexpensive Medigap plan if you choose the high deductible level and just give yourself some protection. But yes, you've interpreted that correctly. That is exactly how it works. Question from the virtual audience.
The question, our
So plans D and N are very similar. The only thing that's different is you have copays for office visits and ER visits on Plan N. But I will tell you that in the state of Illinois, most insurance companies sell Plan N, very few sell Plan D. Okay, so the availability of Plan D simply is not there in the market. And what you'll find when you're price shopping is that Plan N will be much cheaper, even though the coverage is very, very similar. Okay. Okay, so we're going to take a rational assessment of our needs. We're going to look at companies, do our research, work with a broker. Okay. There's never a charge. If anybody charges you for that guidance and assistance, don't work with them, because we get paid by insurance companies for processing enrollments, but the prices are exactly the same. So they're set and they're not any different if you call them, if you try to do it online yourself. But I have seen people make a lot of mistakes in this landscape. Remember, upon activating Part B and stepping off of other qualified coverage, that's the trigger to your open enrollment for a Medigap plan. And it lasts for 6 months from that date. But that open enrollment for a Medigap plan, where you get to choose any policy on this chart from any insurance company and you cannot be denied, it lasts one time. That's a Medicare rule. Okay. Now later you might have other circumstances where you can get certain plans under what's called guaranteed issue, where you're not asked health questions, but you're not going to have an option to choose from everything. You're going to have a limited option of certain plans, and that's a state by state decision. Once that window closes, these policies are month to month. So they're not tied to this Medicare annual enrollment. You can actually change these any month out of the year. But at that point, if you're out of that 6-month window upon coming to Medicare for the first time, that's when every insurance company in the state of Illinois that sells these products, except for one, is going to ask you questions about your health and pull your medical records. And at that point, they'll just say thanks, but no thanks. Now, it's not all involved like life insurance. Nobody comes to your house. You literally just fill out the questionnaire on the application. They might give you a phone call if you answer yes to anything. They'll want you to explain. They'll look at your prescription drug list. They'll look at your health history, usually for the last 2 years. And then they'll just decide. In some rare cases, they might rate you up to a higher price point. Okay. But that higher price point might not be something you're wanting to pay. Okay. So usually it's either you're denied or you're declined. And they're looking for big things. They're looking for combinations of certain conditions, certain medications. Okay. So, and usually they're looking for 2 years post-op on most procedures. Okay. So if you just had a knee replacement, don't try to change your Medicare supplement within 2 years, because you're probably going to be denied because you're not 2 years post-op yet. Okay. Also, if you have something pending, maybe you just need cataract surgery, but it's scheduled for next month. You're going to have to wait till after the cataract surgery to apply for a different supplement. Okay. So little things like that can preclude you from getting coverage, but usually there's some of things are around timing. Some things are around just, they're challenges with your health, and, they're going to cause you a problem moving around in the future. So make a good choice initially, wisely. Medicare also, I should say, can never drop you from these policies. Okay, you're theirs and they're yours until you decide to move away from them. The only time they can drop you off of coverage is if you fail to pay your monthly cost, your monthly premium for the plan. Okay, don't forget to pay your premium, or they can drop you from. That's the only recourse. So, but if you and I come into Medicare at the same time, we both pick the same plan, and then I go on to get stage 4 colon cancer and rack up $1 million in cancer treatment, they're not going to treat me any differently than they treat you. Okay. That's the beauty of this system. You're protected. Okay. So no drop, guaranteed issue in the beginning. Can't be singled out for a rate increase either. Okay. Just because I filed $1 million in claims, they're not going to rate me up. It's not like auto insurance. Okay. Trust me, I've got an 18-year-old new driver. Within the first 2 months, he cracked up both cars. My premiums are going to be through the roof at renewal time. Okay. That's not the case with these types of plans. They will go up in price every year as you age, but that's, you're protected otherwise. Question?
Yeah. So if you select like Plan G and you go with the non-high deductible, and then you say, you know what, I want to switch to the high deductible.
Yeah. You can.
Because you're already in the Plan G, can you move from one G to another without?
So here's the thing. If you're out of your 6-month window for a Medigap plan, this is 3-4 years later, and you just make a change, you decide I want different coverage or I want to shop around for a better price from a different company. It doesn't matter if you're trying to move within your existing company or you're trying to move to a different company, you will have to answer the health questions. Now, let's say you're with a certain insurance company and you just want to move different plans, but stay with them. But they don't let you because there's something in your health history and they deny you coverage. Because you had too many yes answers on the health questionnaire. They cannot take away your current policy from you. They cannot rate you differently, treat you differently, change your price. So there's no disadvantage to trying to move around if you feel you want to make a change. But working with a broker will give you some guidance about the practicality as if it's really, worth it or not. Because we deal with underwriters every day and we kind of know what you're going to get declined for. Okay. All right. Now, you've got your backup coverage to medical, but we all need drug coverage. So if you're in the path of original Medicare, and remember, your network on this side of the equation, folks, any doctor anywhere in the US that accepts Medicare. So it doesn't matter who your Medicare supplement plan is with. No one's going to ask you, you're not going to need to ask any provider, do you take X, Y, and Z supplement? Okay. The only question you need to ask them is, do you take Medicare? Because if your Medicare works, your supplement's going to work. And these travel with you. If you decide, you're going to travel in retirement, or if you're going to be a snowbird, like everything's going to work everywhere in the US with any doctor that accepts Medicare. If you relocate, you won't need to change these plans. You can take your Illinois policy with you. Okay. Now, if you're in a new home state, 3, 4, 5 years down the road, and now you want to make that change from a high deductible G to a standard G, you're going to have to apply for a supplement in your new home state and you will be medically underwritten. Okay. But as long as you're not making any changes, everything goes with you. Your Part D drug coverage works a little differently. Remember, I said there's a late enrollment penalty if you don't enroll when you lose your other creditable drug coverage. You got to get that in place within 63 days. The late enrollment penalty is negligible. Okay. It's about 10% of the average Part D premium per year. So last year, the average premium was around $36, $38. So it was 36 cents, 38 cents, right? But what they do is they tack it on every month that you didn't have a drug plan, that you could have had a drug plan. And then when you finally do decide to jump into Part D, they add up that cumulative penalty and they tack it on top of your monthly premium cost every month in perpetuity for the rest of your life. Okay. So it's not a one-time penalty. It lives with you for forever. And you don't want to avoid it just because you're not taking any prescriptions. Now, the good news is insurance companies recognize that you all are aging better at 65 than your parents were at 55, right? You take walks after dinner, you put kale in your smoothies, you're taking lots of multivitamins. So life is good. And they recognize that a lot of Medicare beneficiaries don't take prescription drugs. And years ago, people were getting grouchy because these drug plans started out at $35, $40 a month. Well, guess what? Now there's some under $10 a month or just over $10 a month. So if you're one of those lucky people that has been able to stay off of prescriptions, there's a plan for you. Just get your foot in the door. It's super cheap to do so to avoid the penalty, but don't take a pass, because if and when you decide to take a pass, usually what happens is you go see your primary care doctor and all of a sudden they put you on something like Xarelto or Eliquis because it's going to change your life, make you feel 1,000 times better. Okay. These are $400 or $500 drugs and you're going to go to the pharmacy to fill them and you're going to just about fall over because the pharmacist is going to say that will be, $450 for a 30-day supply. And you're going to go home and complain to your neighbor about it. And they're going to say, hey, why don't you call that Medicare lady that we saw at the seminar? And you're going to call me and it's going to be July. And I'm going to have to be the bearer of bad news. And I'm going to be able to tell you that I can help you on October 15th and sign you up for a drug plan that's going to cover your Eliquis or Xarelto, but it's not going to start till January 1st. And you're going to have to pay out of pocket until then. Okay. And because you've deferred on Part B or Part D, I'm sorry, you're also going to have a penalty that's going to be added onto your plan premium forever. Okay. I don't like sharing that news. People get kind of grumpy when I do, but all I can do is cheer you on the sidelines. So just know that the annual election period, if you take a pass initially, is the only time that you can switch up your drug coverage. So you don't want to be penalized and you don't want to be locked out when you do really need a medication that could be life-saving for you. These plans are not a one size fits all. All right. A lot of people will just go onto Medicare.gov. All the new plans got published last Saturday for calendar year 2023, and they'll just pick one based on the price. Okay. Not the way to pick a drug plan, because every Part D plan covers a different set of drugs. That's called their formulary. Now, Medicare sets a master formulary of all the common prescription drugs people take in Medicare. But off of that formulary, each insurance company decides what they're going to cover. Okay. And each insurance company has 2-3 plans in the market every year. Some are designed around generics, some are designed around brands, some kind of have a mix of both. The premiums are all different. The deductibles can vary. How the deductibles apply can vary. And so just don't be blindsided. You definitely have to look at this in a very specific way related to what you're filling. Okay. There are common stages of coverage on every Part D plan though, and I want to talk about that in a minute. So this is the 3rd page of your handout, okay? This shows you those stages of coverage. Now, standard are the 3 stages of coverage called the initial stage of coverage, the coverage gap, also known as the donut hole, and catastrophic coverage. But I will tell you that probably 3/4, 7/8 of all plans that are available in the market, they also include a deductible, okay? How you move through these stages of coverage is completely predicated on what you are filling. Is there a question from the audience? Okay.
So I think I'm reading this right. Does enrollment for D have to be delayed to July 1, like A, if you turn 65 in January 2022? But don't enroll until January 2023 because you're covered under an employer plan.
So if you're covered under an employer plan, you can take a pass on everything. It is likely that once you are an over 65 employee on the plan, your company will likely send you a letter maintaining that the drug coverage that is part of your group insurance is creditable in the eyes of the federal government. Hang on to that letter, because you're going to need that letter later when you finally decide to retire, step off the plan, and enroll in Part D. Okay. But generally most group insurance policies have drug coverage that is deemed creditable or at least equivalent to Medicare Part D. But you just want to make sure that you double check that with your benefits administrator. But yes, you should be able to defer on that as well. Yep.
So in answer to the follow-up to that,
Mhm.
it depends on when you lose your full healthcare coverage.
Correct.
So if you an employer-sponsored plan.
Yeah.
So if in 2 years from now, that person still is being covered and then they stop coverage, then what is it, 60 days?
63 days. Yeah.
63 days, they have to apply for Part D.
Right. So here's the question about timing when you defer past age 65 on anything related to Medicare, especially things like B and D and A that trigger penalties if you don't do them at the right time. If you're working, your company has more than 20 people, they've maintained that the drug coverage on the plan is creditable. You can let everything ride until you're ready to retire at whatever age that is and step off of that plan. But when you do enroll in these pieces of coverage in Medicare, Part B and Part D in particular, you will have to show proof of that coverage. And there will be forms that that your employer will need to fill out to document that for you. Okay? Sure.
Just a follow-up. So the concern is that planning to retire in April 2023, but turn 65 in January 2022, so haven't signed up yet. So worried about that July 1st date.
So the July 1st date is not relevant to that person's situation. So you're turning 65 in January, you're planning to retire in April, okay? You're still going to be in your initial enrollment window, which is the 7 months around your 65th birthday, okay? So that July date that individual is recalling from earlier in the talk is only related to people who miss their initial enrollment opportunity. They miss their special enrollment opportunity upon retirement, and now they're coming in kind of late in the game, right? The only time Medicare allows people to jump into their original Medicare benefits, Part A and B, is in the first quarter of the year. And those are the folks that get deferred to that July 1 start. But in that individual situation, they're turning 65. So they're going to be in that.
They turn 65 in January 2022.
But that's okay. They turned 65 in January of 2022, but they're retiring in April of 2023. They're going to come to Medicare under a special enrollment reason for loss of employer coverage. So if they didn't turn on either of their benefits, they can turn them on at that time. Again, Part A is going to roll back by 6 months from the date they apply. Part B is going to be forward. So they're going to want to get in. If they're group insurance, so this is the important thing. People always think about their retirement date because it's a happy day, right? But what you have to think about is, when do my insurance benefits cut off? Do they cut off the last day of the month that I retire? Or do they cut off my last day of work? Because Medicare benefits, Part A, Part B, Part D, Part C, they can only start on a calendar month. Okay. So if you're leaving mid-month and your benefits are ending on the 15th, you might have to enroll in Medicare a month early and have an overlap paying for that Part B. Now we don't have to start your supplement or your drug plan or your Advantage plan, whatever you choose, until you're completely off the group, but you might have an overlap in the B benefits simply because you don't want to, have a gap in coverage. I don't know what happened here. Okay. So let's go back to Part D drug coverage. Medicare is going to move you through these stages of coverage based on the value of the drugs that you're filling. Okay, let me repeat that. Everybody in this room at some point is going to have Medicare Part D drug coverage, right? Might be part of an Advantage plan, or it might be something you choose separate, but you're going to add it to your benefits. And that plan might cost you some amount of money per month. And you might be filling $700 worth of drugs. And that plan might allow you to fill those drugs for a $70 copay at the pharmacy. So you get your $700 worth of drugs for a $70 copay. And maybe you had a deductible for some of your medications that you had to pay off, but you've paid off that deductible. And now you're in this initial stage of coverage paying those copays. Every time you're filling your meds, Medicare's not tracking what you're paying. They're tracking the value of your drugs. And they're going to add up 700 plus 700 plus 700 plus 700. And when you reach $4,430 worth of drugs this year, okay, then Medicare is going to say, okay, time out. We're glad we were able to support you, but now you're going to fall into the coverage gap. And in the donut hole, not a sweet place to be, because you're going to fill your same set of medications, and instead of costing $70, each of your brand name drugs and each of your generic drugs, you will pay 25% of the retail value. All right. So some of the meds might go down in price. Some of the meds are definitely going to go up in price. It just depends on what you're filling. And you're going to stay in this level of coverage, paying that higher amount until your combined out-of-pocket costs that you've paid and how the insurance has supported you between these two middle stages hits $7,050. So the moral of the story is, it costs a little bit of a small fortune to get rate relief in Medicare Part D. Once you hit catastrophic coverage, the price of all of your medications go down. Okay. Generics are $3 and change, brands are $9 and change, but no more than 5% of retail, whichever is the greater. Okay. This is how Medicare tries to cost contain out-of-pocket prescription drug coverage, but it still costs people a lot of money if they're filling relatively expensive brand name drugs, because we don't all have options for generics on every medication that we're taking. Sometimes we do. And if we do, have a clubhouse meeting with your doctor before you come to Medicare, because if you're taking the brand, you're definitely going to want to switch to the generic equivalent if you can tolerate it, because it'll impact your movement through these stages of coverage. Question in the back.
Yeah, so the 70/50, the total out of pocket, is that your out of pocket, or is it yours and the health plan's out of pocket?
It's the combined number. Yeah. So it's a little misrepresented or misnamed, I guess, by Medicare, because it says it's total drug cost, but they give you credit for what the drug is worth, and then also how the insurance is supporting you and how you're paying. So yeah, but it's still a lot of money, right? And because of this way that Part D works, and every Part D plan works this way, okay? There's legislation pending about capping maximum out-of-pocket drug cost to $2,000. But last I heard, even if that passes through all the channels that it needs to go through, that legislation probably won't go into effect before 2025. Okay. So this is still what we're dealing with in terms of Medicare Part D. So how do we figure out what best drug, what drug plan is best for us? Well, the first thing we need to understand is, how are the drugs that we are filling, how are they tiered? Because Medicare may tier them one way, but the insurance plan we're looking at may tier them another way. And the higher up in tier, the more we're going to pay when we fill that drug. But it correlates to the cost of the drug as well. So your tier 1s and 2 generics, these have been generic for a long time. They're super cheap. You can fill them at a preferred pharmacy for probably no copay or a couple of dollars. But once you get into the brand category, this is the stuff that's advertised on TV, right? Once you're taking a brand name drug, you might, that retail value is going to be higher. So your copay at the pharmacy is going to be higher. And then specialty, this is stuff like anti-rejection medication after transplant, oral chemotherapy, maybe AIDS medication. You know, certainly people who are on specialty medications, they might blow through all stages of coverage in their first few months. Okay. And the rate relief section is really important for them, but they're not the average person. The average person might fall into the donut hole around now, like September, October, right? And then they'll never get out to catastrophic coverage by the end of the year. And the thing about the stages of coverage, they all reset down to 0 January 1st. But that's why the Medicare annual enrollment is strategically placed between October 15th and December 7th. So you can figure out if you've been prescribed something mid-plan year and you need to make a shift because your drug plan doesn't treat it as well, you can make that change in the fall without question. Okay, what do we do? How do we do this? Where do we go about it? You can start on Medicare.gov. All right. This is the new website homepage. They changed it. You can click into the 2023 plans if you want to see it. Otherwise, if you go to this Find Health and Drug Plans tab, that'll take you to the 2022 plans. So if you're coming into Medicare in November, you're going to need coverage for November, December before you go into 2023. Okay. And you don't have to necessarily change your plan, but what you can do is view both years, right? So you can see if the plan that you're filling, you can just let roll over because it's still going to be the optimal plan for you. This is something we help our clients with when we're helping people navigate their initial decisions and throughout their lifetime. But what you'll do is you'll type in your name, your dose, how often you take it, the drug, right? And then you'll get a sort of all the plans available in your zip code that cover your medications. You can sort them from least expensive to most expensive. You click into the detail and you see something like this. This happens to be a $25 a month Part D plan. It has an annual deductible of $480. Medicare sets that number. Next year, it's going up to $505. Okay. But how this deductible applies on a particular insurance plan can vary. Sometimes it applies to all the drugs on all the tiers. Sometimes it applies just to the drugs on the higher tiers. So if you're taking a handful of tier 1, tier 2 generics and your Part D plan has a deductible that only applies to tiers 3, 4, and 5, you're going to be in the copay stage right away for your drugs that you're filling. Okay. So don't shy away from plans with deductibles. Just know how they apply to the drugs you're taking. But the first thing I'm going to look at, and pharmacy does matter too. I see people make a very good conscious choice about their drug plans and then they go to the completely wrong pharmacy to fill it. There are 2 types of in-network pharmacies in Medicare Part D, standard and preferred. You always want to go to preferred because that's where you're going to get your lowest cost to fill. Now, I've seen on some drug plans, standard and preferred pricing isn't that dramatically different. In other plans, it can be wildly different. It can be the difference of having no copay versus a $15, $20 copay for a medication. Okay. And I don't know about you, but I'd rather have that $20 in my pocket for lunch. So you definitely want to be filling at your preferred in-network pharmacy options. Out of network is out of network. You're going to pay full retail at those places. Okay. What I look at when we're doing this for our clients is I look at this retail cost column and I see what is the number that Medicare is going to be tracking to move this person through those stages of coverage. At a run rate of 572 filling their meds, they're going to hit the coverage gap on this plan in August. And they're going to go after deductible from paying $60 a month for all their meds to paying $143. And then they're unfortunately never going to get out and get rate relief before the end of the year. Okay. So there's a couple things we can do here. We can have a clubhouse meeting with our doctor. Can we switch out some of these brand names for generics? That could help. right? The other thing that we could do is maybe if it's no difference to fill this, Ventolin using a GoodRx discount coupon wholesale outside of our plan, we could eliminate $58 in the calculation toward the coverage gap. Maybe that pushes our entrance to the coverage gap out by a month or two, or maybe not, but it's up to you. And I tell people the government requires that you have Medicare Part D. All right. So sign up for Medicare Part D. They don't require that you fill all of your medications under your insurance plan. So if you have a resource like this Mark Cuban's Cost Plus Drugs or Blink Health or Canadian Drugs Online, or if you have a way to get your medications that are keeping you well at a different cost, knock yourself out. Use those strategies. We're all about making sure that you're optimizing your out-of-pocket expenses to the lowest possible level throughout the aging process. So this is one way of how you can take a look at this. We also aggregate into our quoting software all the formularies for all the insurance companies. So we have kind of a couple different views into this, and we can get real granular. And if you're going to be in the coverage gap, we can help you budget for it and know that it's coming at you 8 lanes wide. Right? So you can plan for it. You don't want to be surprised, 1 month over another when you go to the pharmacy and your drug pricing triples, right? Because you didn't understand that this coverage gap thing existed. All right, so that's Medicare Part D, and we've got our supplement, and things are good, and we're moving along in life. And now we're in our late 70s, early 80s, and we're still writing those insurance checks, or the checks to the insurance company for our premiums. And together, maybe one of us, maybe two of us in a household, those insurance premiums combined, they're not $120 and $10 a month anymore. They're maybe $250 all in for each of us, right? That's $600 a year, or no, yeah, $6,000 a year, $500 a month, $6,000 a year. I told you math in my head was not a strong suit of mine. So if you're spending $6,000 a year at $250 each in insurance premium a month, and you're still only going to the doctor a handful of times, maybe once or twice, and you think about how you're using the healthcare system, maybe you might want to start looking at Medicare Advantage. Okay. Now, this isn't everybody's cup of tea. Some people love to start here. They're very low healthcare consumers, and they would rather be in a pay-as-you-go model. That's what this is. This is a pay-as-you-go, folks. There are a lot of Medicare Advantage plans that have zero premium or very low premium. Conversely, there's a lot of Medicare Advantage plans that have $80, $90, over $100 in premium cost per month. Okay. Now this is on top of what you pay for Medicare, right? So you're still paying for that Part B, and the government's still going to collect your money, whether it's coming out of your Social Security check if you're taking your retirement benefits, or whether you're being billed for it quarterly because you're not taking your benefits yet. Doesn't matter. They're still going to collect it, but they're going to pass that 170/10 every month over to a private insurance company. And then all the federal tax dollars that normally go to the Medicare system to make up the difference, because it costs north of $800 to run our benefits in Medicare, not 170/10. So the rest is tax dollars. That's also going to go to that private insurance company. So these are well funded, okay, which is why they can pay Joe Namath to tell you all that it's free, and free. But you know better. You know that your healthcare isn't free. That's why you're here tonight. So you want to find out what this is all about. Well, that's what this is about. This is a private insurance product that doesn't really have to charge you a lot up front because they're well funded by the federal government and by your Medicare premiums. However, they are going to get you to pay for your health care. And this is how it's going to work. They're going to charge you co-payments for services. So everything beyond your preventive care is going to have some associated cost. Now, here's the good news. It's going to be a heck of a lot less than what you're paying on your insurance coverage right now as an under 65-year-old, because it's going to be based on the Medicare reimbursement model, right? But what's going to happen is this private insurance company is going to decide what you pay for a night in the hospital, what you pay for a lab test, what you pay for a specialist visit, what you pay to pop into an ER or an urgent care center, or to get an MRI, or to have a knee replacement. They're going to have flat charges for all of those things. And you are going to know what those charges are before you even sign up for the plan, because Medicare is a very transparent system. They oversee Part C plans as well. Okay. They don't run those plans. Private insurance companies run those plans, but they definitely have, oversight, right? So part of that oversight is these insurance companies have to lay out their benefits identically. Okay, which makes it very great for you as a consumer to evaluate your options. But the way that insurance companies keep costs down, right? They don't have to charge you $2,000 for a night in the hospital. They can charge you $200-300 for a night in the hospital. The way they keep those costs down is that they restrict your access. They tie you to a doctor network. Okay. Now, if you've been in a managed care plan at any point in your working years, you know what that looks like. Typically, the most common types of plans are HMOs or PPOs. And if you're doing everything at Northwestern or everything at Advocate or everything at North Shore University Health System, you're already acting like you're in an HMO. Okay. So don't think an HMO is a bad option. It's not. Okay. But do keep in mind that by being in an HMO, you pretty much have to do everything within a single medical group because you are going to need a referral from your primary care physician. And if your primary care physician is in that medical group, they're not going to refer you out of that medical group. They're going to refer you within it. Okay. So it could be a great way to keep your costs low in Medicare, but it's not for everybody. Okay. If you're a snowbird, if you plan to see the USA in your Chevrolet in retirement, do yourself a favor, at least go for a PPO. So you have in and out of network benefits. So that way, when you're in Denver and you're hiking in the mountains and you fall and break your leg, okay, might not be an emergency. It's not life threatening, but maybe you can access the national doctor network on your PPO to stay in network for your care, or you can use your out of network benefits. Okay. If you were on an HMO plan, you'd have to break your leg and have a heart attack. That's life threatening. That would be considered an emergency and then they'd cover you, right? But the devil's in the details. So you just really want to make sure that you're thinking about these insurance policies related to your lifestyle. Okay. Your lifestyle and how you want to move freely from this point forward through the healthcare system. That's a personal decision that you need to make. Okay. So these plans are all shapes and sizes. In Cook County alone, we have 52 different Medicare Advantage plans to choose from. 52. Okay. So that's the first filter, by the way. These plans are sold by county. So we're going to look at your county and say, okay, you have 52 options. And then you're going to say, Robin, I only want to look at HMOs. All right. We're going to cut it down to 25, right? And then you're going to say, okay, Robin, these are my doctors. These are who have to be in network. We're going to look at those. And then you're going to say, these are the prescriptions I need filled. And then we're going to look at those. Okay. And then we might have 3 or 4 good options for you. And out of those, we're going to look at low cost, no cost plans. We're going to look at your max out of pocket to be the lowest it possibly can be. Okay. Because these plans have that capped exposure that you're used to, right? If you're going to be paying for hospital stays and ER visits and tests and scans and labs and x-rays and specialist appointments, that money is going to count towards some maximum number. Now on a HMO, one number, because you're going to do everything in network. On a PPO, you're going to have in and out of network benefits. Okay. So those numbers are going to be different. Obviously, they're going to be higher if you go out of network because you're going to pay more out of network. A lot of times, most often, these plans also include Part D drug coverage. So that's great. You don't have to go pick that up separately. The Part D plans within a Medicare Advantage plan work just like they do standalone. Okay, so 5 tiers, sometimes 6 tiers, the same stages of coverage. Okay, but there might be cost advantages to certain medications of yours within a Medicare Advantage plan. Okay, so we got to look for those kind of golden nuggets, and we know where they're hiding. We deal with these plans every day. Your time to choose one of these plans, if you don't choose it initially, like maybe you started with original Medicare and now you want to try one of these on for size, is during the annual election period. So these, just like Part D drug plans, they run on a calendar cycle. Okay. Now, does anything need to be renewed this time of year? I mean, Joe Namath, Jimmy Walker, Lionel Richie, they're all going to be hollering at you over the TV in a couple weeks. You're going to get all that advertising that's going to tell you free, free, and free, and you're missing out on free this and free that. Some limo is going to come to your house and take you to your dentist appointment for no cost, right? You don't have to do anything if you don't want to. If it ain't broke, don't fix it, right? But do ask yourself a question. How's it working? Has anything changed? Have my doctors changed? Have my medications changed? Okay. But this time of year, I find that a lot of my clients get together for lunch and for dinner and for drinks, and they start talking about what they got and what do you got and what do you got? And they compare notes. Okay. And solicit all the advice you want. Chat about these things. It's important to talk amongst yourselves, but I do want you at the end of the day, when you're thinking about your choices, to be very selfish. Think about you. Okay. Don't worry that, your best friend over here is doing this, that, and the other. What do I need? Because chances are your doctors and your healthcare needs and your budget and your lifestyle looks a little different than your best friend. Okay. So you really want to take that into account when you're making choices here. The other thing to just keep in mind, you got to be enrolled in Part A and B. Now, there are certain plans that will be advertised next year that have what they call a Part B give back. Okay. They're very few and far between. Many of them are plans that are defined around the veteran community or low income community. So you have to qualify for that. Okay. But it's a nominal amount. The only people who ever gets their Part B premiums paid for, like I said, are people that have full Medicaid benefits. That's a state assisted benefit. These replace Medicare. So you're going to get your shiny new red, white, and blue card in the mail, but you're going to stick it in a drawer. If you have a Medicare Advantage plan, you're going to have one card. You're going to show it at the doctor, the hospital, the pharmacy, the gym, the gym, the dentist office, everywhere you go, that's going to be your card. Okay. You won't show your Medicare card. Again, these plans are available by county. So if you're talking to your best friend in Tennessee, or if you're talking to your cousin in, I don't know, Lyle or Northbrook or Northbrook's the same county as here, but you know what I'm saying? Like if they're down in Kankakee, right? Oh, that's right. So, well, there's a division in Deerfield, but in any event, if they're in a different county, the same plans might not be available, right? So in Illinois, a lot of them across counties, but just know that's kind of the first filter around what you can choose. And, I like Joe Namath, but I don't like the way he talks about Advantage plans. And yes, there are many extra benefits in Medicare Advantage. Okay. These are things that private insurance companies, they're not stupid. They know that Medicare leaves you open to self-insure for some of your preventive care. The government can't afford to give you a refraction exam and an eyewear benefit for your bifocals or your contacts. Okay. They can't afford to give you hearing aids. They can't afford to give you 2 teeth cleanings a year. They got you covered for your eyes, ears, and teeth for illness and injury. If you trip on the sidewalk out of here, tonight, and you knock out your front teeth, they're going to pay for that dental work. They're going to cover you for your cataracts and glaucoma and macular degeneration screenings and surgeries and treatment. But, if you're wearing expensive $800 trifocals like I am, you're not going to get that covered. Okay. So same thing, illness. If you have an illness where your hearing gets degraded and now as a result, you have to wear hearing aids, medically necessary, that kind of thing, Medicare will cover. But if we're just getting old and we worked at a factory our whole lives and our hearing isn't the best, that's on us, right? So a lot of these private insurance plans in Advantage have added these extra benefits to compete with Medicare to draw you into the plans. Are the extras why I would buy one of these plans? No, but they're sure nice that they're there. Okay. But the thing that you really need to be mindful of when you're evaluating this option for coverage, are my doctors covered? Are my drugs covered? Does this meet my needs and lifestyle in terms of how I want to move through the healthcare system? Okay. And is the cost structure in the plan affordable to me? The premium, the copays, the max out of pocket. Okay. If all of those things check the yes box for you, this can be a great way to start. It can be a great way to evolve to at some point throughout the aging process, but the option is open to you throughout your lifetime. Okay. It's an either or choice. One side or the other side, can't have both. Okay. And so if you need help in navigating that landscape initially, or at some point in the future, give us a call. The advice is free. We'd love to help you get to your answers and your decisions a lot more quickly. There are other resources you can call. You can work with a SHIP counselor. You can call those folks at Medicare.gov. Signing up for Medicare, your Part A and B benefits, that's between you and the Social Security office. Okay. So I can guide you. I can tell you about the timing. I can give you the forms. I can send you the links. I can help coach you through that process. I can't do it for you. Okay. But once you've got that going, if you need help picking any of this other stuff, okay, the D piece, the C piece, the supplement piece, don't worry. When you sign up for Medicare, Social Security is not going to ask you about your decisions related to those things. You do that after the fact, but we'll line it up to all happen around the same time. Okay. Well, I want to thank you for your attention tonight. You asked some great questions. Do we have any more from the virtual audience?
No, just some people saying thank you for a great presentation.
Oh, good. I'm glad it was helpful. This is a very kind of complicated topic only because there's a lot of moving parts, but we do have a question from the audience.
Yeah, I do have one other question. traditional Medicare doesn't cover you if you go out of the country?
Well, so the question was, does traditional Medicare cover you out of the country? No, because it's not recognized out of country. It's the U.S. healthcare system, health insurance for seniors, right? So if you're traveling to Ireland on the trip of a lifetime and you fall and break your leg, okay, you're going to settle up out of country and bring your bills back to Medicare. Okay. Now, some Advantage plans have worldwide like ER coverage, right? So you could pop into an ER or an urgent care and pay a flat copay for stuff like that. But I want to point out something. Your supplement plans, some of them do have, do you see in this last row, 80% foreign travel emergency? Okay. So what happens if you have that medical event out of country and you have a Medigap plan? You'll settle up out of country, bring the bills back to Medicare. Medicare will pass the entirety of that bill to your supplement company, and they will pay 80% of that event. You'll be on the hook for 20%, and they will charge you a separate deductible above and beyond the $233. So the deductible is $250. Okay. And the 80% that they will cover you for, it's capped out at $50,000 in your lifetime. Okay. So that's not a lot. Medical expenses overseas are a lot less than they are in the US. I know this because my husband had an emergency appendectomy in India and he was in and out for $5,000. But, you know, same thing would have cost $100,000 here. But the bottom line is that it does have a cap on it. And so I always tell people, if you're going to be an extensive foreign traveler, if you're going on the trip of a lifetime, we do also help put in global travel insurance, major medical, that will work out of country. Turns on when you leave, turns off when you come back. I have a lot of clients that have those policies. They're easy enough to do. They're with a major insurance company, and we can help you with that as well. I have a lot of clients too who, you know, for their jobs, they went on Medicare, but, you know, I have one client who's a concert pianist, travels all over the world. And he has a policy that lasts for a whole year and just turns on and off when he leaves for different events. So there's all kinds of ways we can go about bridging that gap if you're going to be out of country for a chunk of time. Okay, great question.
Advantage plans,
Mhm.
they cover foreign travel too?
I mean, so there's some foreign travel emergency coverage that's in there for nominal copays, but then you're going to have to bring your bills back and again, settle up, and most of it's going to be out of network. Which is even more reason why you might want to get that major medical coverage through a global travel plan. One thing to note about Advantage plans, everybody always talks about leaving Illinois. What if we leave Illinois? I don't know why you would leave the state of Illinois in retirement, but if you decide to go somewhere else, a little more glamorous, a little more warm in the winter, like I said, supplement plans travel with you, but if you completely relocate, the only thing you'll really need to change is your Part D drug coverage. Clearly, if you're on a Medicare Advantage plan, okay, if you're over here on Part C, those are sold by county. So you're going to want to get off that plan either right after you move or right before you move, because you're going to want to establish, you know, new doctors. But at that point, you will have a special enrollment reason to change for relocation. And you can either change your Advantage plan to another Advantage plan, or you can go to original Medicare. But again, you'll get an opportunity to put the drug coverage in place for that event, but you'll have to apply for the supplement in that state. Okay. There will be no guaranteed you get it guaranteed. All right. Any other questions? All right. Thanks, everybody. Appreciate your attention.